So I'm going to start with my case. So a 53-year-old woman with a history of uterine fibroids who presents with palpitations, fatigue, and lightheadedness. She was found to have a hemoglobin of 4.4 with iron deficiency anemia. She was initially thought to have abnormal uterine bleeding, but after day 1 of her presentation, she had a large volume hematemesis episode, obviously resulting in an EGD. And so she had a first EGD that showed a large clot in the cardia and the fundus of the stomach. We tried to remove the clot piecemeal with both suction and Rothnet. Unfortunately, we weren't successful. So we had to give her erythromycin and repeat the EGD the following day. Does anyone want to hazard a guess as to what's under this clot?
I will. I'm kidding.
Dr. Greenwald did this case with me, so don't cheat. All right, so.
A Dulafoy.
Right, so that's what we thought initially, given the volume of bleeding. But then the following day, we went in and saw this.
Ooh.
Nice.
And so this is a smooth bulging mass with normal overlying mucosa. As you can see, it has a central kind of ulcer in the middle there. So it's an exophytic lesion that's outgrowing from the mucosa. And so that is consistent with a GIST, a gastrointestinal stromal tumor, which was confirmed by our path. And I don't know if Dr. Harpaz, if you want to go ahead and talk about path.
I'm going to try. Do you hear me?
Yes.
Oh, wonderful. Okay. Okay, this is technically difficult because I'm not in my office. Anyway, let me show the, let's see if I can show I'm going to share the screen. Hold on. A second. Okay. Okay. All right, I was going to show you digital images of this, but unfortunately I can't get the image up. Just one second. All right, I'm not up to the technicalities of Zoom. I apologize. Here, I am screen sharing. Okay, in any case, it was so it was a spindle cell tumor, which I was going to show you. There's a standard protocol for distinguishing GIST, which is the most common spindle cell tumor in this location, from lookalikes. In fact, for many years, GISTs were mistaken for smooth muscle tumors until it was recognized that they're in fact not really composed of smooth muscles. So there are 2 stains that are normally done, which I'm unable to show you. Those are, their names are Dog 1. Don't ask me what Dog 2 is, but I'll tell you what Dog 1 is. It stands for discovered on GIST. And this is an extremely sensitive and specific stain for GIST. And the stain that was used before that is the more familiar C-KIT or CD117 stain, which is a little bit less specific. So we in fact use both. These were very strongly positive, which is what I'm not able to show you. Then we also do several stains for other lookalikes, which would include muscle tumors. So we do a smooth muscle actin stain. For neural tumors, we do an S100 stain, et cetera. And those were negatives. So this was strongly positive, was clear cut. Just the other things the report didn't indicate anything about one of the prognostic factors, which is the mitotic rate. So in general, GISTs are, we prognosticate regarding GISTs based on 3 factors. One is the location. It actually makes a difference where it is in the GI tract. So for example, if you had 2 equal GISTs, one in the stomach, one in the small bowel one would probably behave worse. So location. Secondly is the mitotic rate. And third is the size of the tumor. And we actually use a chart. There was a study done with hundreds of cases, and they looked at the rate of metastases. So we can actually give you a pretty good estimate as to the likelihood of recurrence. Now, the gastric cyst, it was only a few centimeters in size, and that alone, and with the location, means that it is very favorable prognostically. The report didn't mention anything about mitosis, maybe because it was just a small sample and it could be misleading. But I presume that it was not, it would have to be extremely loaded with mitosis in order to be of any concern, but we can go back and look at that. Okay, so sorry I can't show you the images, but we'll have to do it.
Dr. Harpaz, it's been reported that one of the higher risk factors for the mitotic count is more than 5 per high power per 50.
Right, so there are two thresholds. Right, there are two thresholds. One is, so we count actually 50 high power fields or 5 millimeters squared on the slide. And we count mitoses, and if there are two thresholds, one's above 5 and the other's above 10. Anything above 10 is horrible. Above 5 puts it into various categories depending on location. In this case, you know, it probably wasn't even enough tissue to do the proper count. So it's okay not to mention anything. It'll probably have to come out, and that's the best place to assess it. So in terms of size, in the stomach, 5 centimeters is the cutout. Anything under 5 is probably going to be fine. Anything above 5, then we have to throw in the other factor of the mitotic count. Then if the mitosis above 10, for example, so even a small tumor of 5, 6, 7 cm, which we would consider small, would be more serious problem. So I doubt there'll be an issue with this, but we really can't tell till it's resected.
Thanks so much.
Thank you, Dr. Harpaz. And so, so I'll review a lot of what Dr. Harpaz just mentioned. So for GISTs, briefly, they're mesenchymal tumors. And so they're essentially sarcomas and tumors of the connective tissue. 70% of them are found in the stomach, 20% in the small intestines. They're quite rare. They comprise about 1% of all GI tumors. And the median age of diagnosis is anywhere from 66 to 69 years. The presentation can vary. If they're small tumors, they can be asymptomatic and actually be found incidentally. If they're larger tumors, and they often present with GI bleeding and abdominal discomfort. And basically what we saw endoscopically is very characteristic of what they look like. And so, you know, they're these like exophytic masses. They are different from adenos in the sense that they're not circumferential. Again, they're just kind of like an outgrowth from the mucosa. They very rarely cause obstruction like adenos. And because of this, they very rarely metastasize to the lymph nodes. Actually, they met primarily to the liver and sometimes to the lung. And as Dr. Harpaz mentioned, so not all GISTs are malignant, but they all have malignant potential. And so several guidelines have essentially characterized the malignant potential of GIST based on the tumor mitotic index, their size, and their location. And so the most common guideline that's used is the National Institutes of Health. And so this is just a brief schematic of what Dr. Harpaz was mentioning. So as the mitotic index increases and the size increases, the malignancy potential also increases. And interestingly enough, the small intestine actually has a higher malignancy potential than the stomach. And so, you know, what if we don't take resected lesions? How can we endoscopically kind of determine the or predict the malignancy potential? And so, so EUS actually, with or without FNA, is the preferred imaging technique used to further characterize subepithelial gastric lesions, including cysts. And a lot of the guidelines actually refer to studies similar to this one that I have here that was in 2008. Published in 2008 in Digestive Diseases and Sciences. But essentially it looked at patients who were diagnosed with GISTs and had an EUS from January 2000, 2006. And it compared two things. They took their path reports and classified them based on the NIH classification, as I mentioned earlier, risk stratified them with, you know, very low, intermediate and high risk malignancy potential, and then a blinded sonographer who then looked at the corresponding EUSs and noted tumor size, irregularity of the border, local invasion, and heterogeneity. And there was a direct correlation between the malignancy potential noted by the classification and essentially, increase in size, worsening irregularity and invasion and heterogeneity. And so this essentially has helped inform our guidelines. And so the ASGE has a guideline that was published in, I think, 2015 in the role of endoscopy in the management of pre-malignant and malignant conditions of the stomach. Obviously, GIST falls within this category. And ultimately, if a patient is symptomatic, any symptoms at all from a GIST, that's easy. They automatically should get resection. If they're asymptomatic and their tumor size is 2 centimeters or greater, they automatically could get surgery. And this 2 centimeters kind of goes back to that study that I mentioned earlier, and several other studies that noted that tumor size anywhere from like 2 to 5 had an intermediate malignancy potential. And so that's where the 2 centimeters come from. And then I think this is actually the bucket that's most important for us as endoscopists. If the tumor size is less than 2 centimeters, the patient should always get an EUS, again, being the preferred imaging modality. And if the EUS shows high risk features, then they should get surgery. And high risk features, as we mentioned, are the lobulated irregular borders, ecogenic foci, or cystic spaces. And again, that was what we noted in the prior study. And here I just included a picture with the cystic spaces and irregular borders. And if you actually have 2 out of these 3 features, then EUS can be anywhere from 80 to 100% sensitive for malignancy. And I think this, for us, is also very important to note. So if a tumor size is less than 2 centimeters and not having a lot of high-risk features, then what do we do for surveillance? And we actually, the guidelines suggest that we should get an EUS every 6 to 12 months. I'm not sure what our advanced folks do in practice, but that's pretty well kind of documented within our multiple guidelines. And then additionally, our oncology guidelines essentially say the same thing. So the National Comprehensive Cancer Network note the same algorithm, but they take it a step further. If a lesion is resected, they actually recommend abdominal imaging every 3 to 6 months for 3 to 5 years, and then annually thereafter. And so in conclusion, my patient did ultimately get a CTA and chest. It did show some liver lesions that were concerning for Mets versus hemangiomas, but ultimately she was referred to onc and surgery, and they recommended a resection and further management as outpatient. Do you guys have any questions for me?
Jamil, a couple things. Can you go back to the guideline slide that you had? So, this is an interesting case. What you were actually seeing endoscopically was the endophytic component. So it was the intraluminal component of this GIST, which typically arises from the interstitial cells of Cajal. The exophytic component, what's going beyond the luminal surface, really can only be truly assessed by either EUS or by CT, because that's what extends out into the abdominal cavity. This guideline, I think you said, what year was it published?
2015.
Yeah, so I would argue that this is already out of date, even though it's only been 5 years. And I'll explain why. So we do have, number one, the ability to remove or resect endoscopically small GISTs. So traditionally, when we look at these lesions under EUS, they most commonly arise from either the muscularis mucosa layer 2, or the muscularis propria layer 4 within the GI tract. And when they're small, typically 4 or 5 centimeters or less, we can actually use an endoscopic tunneling technique to access the 3rd layer, the submucosa, and in a controlled fashion, be able to dissect within the tunnel around this lesion and ultimately remove and excise it. And later in the year, I can show a video that sort of describes and shows this technique. It's called a submucosal tunneling endoscopic resection, or STIR. So again, we basically tunnel in the submucosal space to the lesion, and then within the tunnel actually resect the lesion and remove it in its entirety. So These patients traditionally, if it's like 4 or 5 centimeters or less, do not need to go to surgery anymore because we can resect these in a minimally invasive fashion. The other thing that has changed is that we are having conversations now with our patients where they have a small tumor size. Traditionally, by the NCCN guidelines and by this guideline, as you suggested, the typical recommendation without high-risk features was to, have interval EUS surveillance. But frequently, all of us, myself, Chris, Satish, are having conversations with our patients, particularly our younger or middle-aged patients that have these incidentally found GISTs. And the reason is that we can perform safe endoscopic removal of these lesions in basically one short procedure, and therefore remove the need for multiple EUSs over the span of their lifetime. And I can tell you that the majority of patients are opting, even with smaller GISTs, to have them endoscopically removed so that they don't need to have continued endoscopic surveillance. The one location that is challenging for us endoscopically to resect that does give us a little bit of pause is in the fundus, because as you can imagine, that scope has to be U-turned or retroflexed for the resection, and that can be very challenging for both dissection and for closure. But we have been able to do some, resections in that area. So again, it's the guidelines are really good, but I would argue that in today's day and age in 2020, even though this is only 5 years old, this is already outdated.
So I have two questions. The first is for Noam. If these GIST tumors arise from the interstitial cells of Cajal, aren't those cells located in the myenteric plexus? Shouldn't all of these lesions arise from from the muscularis propria?
That's a very good question, and in fact, that it worked backwards. Historically, it was noted that these tumors practically always arose from the muscularis propria layer, as you say, and that's what actually stimulated the search for cells of origin in the myenteric plexus. So the answer is almost always yes, but there are exceptions. You can get GISTs arising from the serosa. They'll arise in the peritoneal cavity without even any attachment to the GI tract. As far as the ones from the submucosa, those are very rarely actually GISTs. There's a group of GISTs that arise right at the GE junction, but on the outside, on the adventitial side, they're generally small and they're almost always benign. We call them gistlets. They're like one or two centimeters in size. So they're actually quite varied in location. But what you're saying is correct. Generally, I would imagine it would be very, very challenging to remove these without, doing a full thickness resection based on, based on location. I should point out that there's something called a dumbbell tumor which was where Nick alluded to this, where you get an endophytic component going in, then you get another component that grows out into the peritoneal cavity, so a full assessment of the size requires imaging.
And the second question I had, if Jamila, can you go back to the endoscopic photo? The surface of this lesion is very smooth, and I wonder if the endoscopists, there was a still picture, I think. Yeah, right there. So it's very smooth, and to me, I don't know, maybe the endoscopist can comment. I would imagine that if it was an adenocarcinoma, the surface would look more, like a villus adenoma, like you'd have more epithelial proliferation. This looks more sort of submucosal and smooth. Can you just look at this as an endoscopist and say, I can tell that that's a GIST versus an adenocarcinoma?
Yeah, I think that, sorry, go ahead.
I'm sorry. I just want to point out there are other tumors that, that can give you the same presentation, non-epithelial tumors. There's a whole variety. Ranging from metastases, you can get
No, what I'm trying to distinguish is a primary adeno of the stomach versus everything else.
Yeah, typically you would see some intramucosal abnormality visually. Here, if you actually look down towards, maybe towards like 7 o'clock, you can see how that there is more extension, what looks like goes towards the serosal aspect. And they actually, I think Dave and Jamila actually called me into the room to look at this lesion and kind of the first thing that came out of my mouth was this is probably a GIST, because you do get the sense this is a subepithelial lesion. And that ulcer that we could see, there's a couple of thoughts on why these occur with GISTs. One is that the growth of the tumor can restrict the mucosa and can alter the local mucosal blood supply. And so you can get sort of this localized cell necrosis and can ultimately have ulcerative bleeding. Very rarely you can have a hemorrhage that's induced by blood vessel rupture when the tumor invades and erodes through the mucosal or submucosal surface. But our plan had been, if the sort of deep well biopsies of this did not come back diagnostic, that we could do an EUS and sample, because as Noam alluded to, there are other potential causes of subepithelial lesions, not just GISTs. But in this case, we had a very high suspicion for it. Their biopsies were able to get a diagnosis, and we did also recommend a CT to assess for the exophytic component, because sometimes what will happen when you have the diagnosis of GIST is preoperatively these patients will get tyrosine kinase inhibitors in an effort to make them more suitable operative candidates. So there is a role for EUS in some of these lesions, but yeah, because of the smooth overlying surface, there's much less likely of a cause of this particular lesion being a gastric adenocarcinoma.
Yeah, it had a smooth, as Nikhil said, it had a smooth sort of the part right next to the gastric wall was much smoother, and then there was sort of the second part above it. But I thought it was a GIST immediately, if that helps, Steve. So.
Right, in the interest of time, I'm going to let Lauren go, but thank you all for your contributions. This was a great case.
Morning, everybody. Let me share my screen here. Okay, can you all see that?
Yeah.
Yep.
Okay, perfect. So morning, happy Friday. I'll be presenting the second case. It is unfortunately not an upper GI Crohn's case, but something. Okay, so we have a 74-year-old male with peripheral artery disease on dual antiplatelet therapy coming in with a foot ulcer, admitted to vascular surgery for debridement. As part of the pre-surgical workup, Vascular obtained a CT angiogram abdomen pelvis, which incidentally showed colonic and hepatic flexure. The patient told me that he had lost considerable weight in the past few months, although he wasn't able to quantify, and then his GI review of systems was completely negative. He told me that he had had a colonoscopy at the Manhattan VA that was reportedly normal within the past 10 years, but we did not have the report. His vitals were stable. He had an unremarkable abdominal exam, and labs were all similarly unremarkable. He had a mild normocytic anemia with a ferritin of 369. So here's a picture of his CT. So if you direct your kind of attention up to the hepatic flexure, you can see there's a pretty overt abnormality there, which looks like an apple core lesion, some pretty significant colonic wall thickening and narrowing kind of in the center there. So of course we took this patient for colonoscopy, and these are the endoscopic correlates to that imaging finding. So once we were kind of approaching the transverse colon, you were able to appreciate some pretty abnormal mucosa, some narrowing of the luminal caliber. The mucosa was really friable, very gray and dusky. And if you got really up close, you can almost see in picture 15 a really abnormal pit pattern. So we ended up finding kind of a hemicircumferential hepatic flexure mass that was pretty extensive. We took quite a few biopsies, and the pathology unsurprisingly came back with a moderately differentiated adenocarcinoma. The patient underwent a right hemicolectomy and ended up doing very well. So this case just kind of got me thinking. Now, this was kind of an extreme example of colonic thickening on imaging, an apple core lesion, but got me thinking more about, we are so often consulted for imaging findings, and I wanted to know a little bit more about what the data actually show regarding colonic wall thickening. So in kind of doing my literature review, I found a lot of studies that were very small retrospective kind of reports, but they all kind of said different things. So I was happy to have found a systematic review. This was published in 2018 by Frontline Gastroenterology, looking at colonic mural thickening on CT with the as a correlate with endoscopic findings at colonoscopy. So I'll just go over this paper briefly. So a little background, abdominal imaging is on the rise, as we can all kind of tell clinically. Everybody is getting CT for everything. And then advances such as CT multi-detection are continuing to improve every year, which is improving the sensitivity and specificity for detecting GI pathology. This paper and for this discussion looks at colonic mural thickening as defined by greater than 3 millimeters with satisfactory colonic distension. Then kind of on the differential, you've got the first 4 bullet points are really the ones that we would want to. And then the last two, they're the benign strictures and under distension, of course, don't really excite us as much. So the design of this study, the inclusion criteria, they looked at they were aimed to collect prospective and retrospective comparative cohort studies, case controls, and cross-sectional studies looking at adults aged 18 and older with colonic findings only, so nothing in the small bowel or anywhere else in the abdomen. They ended up narrowing down to 9 cohort studies, comprising about 1,200 patients in total that underwent a CT followed by a colonoscopy within 4 weeks. And so here are the results. This study really focused on the positive predictive value, which if you can remember back to biostats, is the probability that subjects with a positive screening test actually have the disease. So here we have the pooled positive predictive value for any abnormal finding at colonoscopy was pretty good at 0.73. The pooled positive predictive value for colorectal cancer when the radiology report suspected or noted a suspicion for colorectal cancer was 0.63. The positive predictive value for thickening suggestive of inflammation was actually very high at 0.97. And then a couple of other kind of interesting facts that I pulled out of this paper. There was no difference in pathology detection between the right and left side of the colon. There's been, if you kind of peruse the literature, there's a lot of studies that kind of insinuate that we might be able to detect left-sided colonic pathology a little bit better on imaging, but this didn't really pan out in the systematic review. So both sides kind of were equally detected. And then I also thought that this was interesting because it so closely paralleled the case that I presented. So there was a high correlation in Caucasians with rectal bleeding and transverse colon thickening as far as, finding an endoscopic finding of malignancy. So my patient was a little visually impaired, so he was anemic and may not have noticed rectal bleeding, but he was a Caucasian with transverse colon thickening. So takeaways from this paper, take imaging findings seriously. There is a high likelihood of an endoscopic correlate, or at least higher than I would have imagined. And then this is especially true for inflammation and malignancy. All right, any questions?
That was actually a curbside for vascular surgery, which I was impressed with. I'm like, I think you need an actual consult.
Yeah.
Hello, I've seen many patients referred for thickening on CT scan in the sigmoid colon, and I've never found any malignancy in those areas. It's usually due to either underdistension or diverticular disease, but I'm not a big fan of thickening in the sigmoid colon, meaning carcinoma is present.
I think that's a really good point. I wish they would have stratified more of where the thickening was. I think that would be a good, I guess, subgroup analysis to see, sigmoid versus they did comment on the transverse. Then I think another point to that is that our imaging technology continues to improve. So our sensitivity and specificity is improving as well. So we may see, a higher correlation going forward.
This is also why I encourage people to continue to look at their own scans. As you start to look at these, you can get a sense for what's mass-like and what's for under distension. Like you can look at how thick the wall is, how eccentric it looks, how distended the colon is. A lot of radiologists won't put their finger down because they're just sort of like correlate clinically, correlate with endoscopic findings. But when you look at this CT, this isn't your classic wall thickening, that sort of non-specific nonsense, because the colon is well distended on both sides. There's an irregularity to the wall. So again, I encourage fellows and everyone to continue to look at your own scans. You learn a lot and can make some more intelligent decisions as compared to what the radiologist is telling us to do.
It's a great case, great comments. In the interest of time, let's send it over to our advanced fellow, Nick, for our last case this morning.
Thank you. All right. So today I'm going to present a case called Houston, We Have a Perforation. And we'll talk at the end bonus points if anyone can connect the title to the endoscopic device. Anyone who's not an advanced endoscopist, you guys probably already know. All right, so today we have a 52-year-old female who actually presented very dramatically with something we don't really see that often anymore, which is a perforated gastric ulcer. And she went straight to the OR and had a gram patch, and they placed a surgical drain during the surgery, but it kept putting out very high numbers. It was like 200 to 500 cc's per day. Although she remained afebrile and stable, probably because of the drainage, without really a significant leukocytosis, they called advanced GI to evaluate and see if we could potentially look for and seal the leak that was allowing for that continuous drainage. So this was her presentation CT. And as you can see, she basically had a frank perforation. She had ascites and pneumoperitoneum. Post-op, this is their scan. So you can see the drain on the left, and it goes right through a large fluid collection with air and fluid. On the right, that's just an axial view of the same. Despite that evidence of a leak, there was actually no extravasation on an upper GI series, but we still suspected the leak based on the drain output. And so we brought her to endo. And here's what we found. So the pylorus is on the right, over here. This is an ulcer on the left. And when we interrogate the ulcer, there is a frank perforation. So this is a full thickness perforation, basically, into the peritoneum. And we proceeded to make an attempt to close this endoscopically. So the first thing we did was we treated it with circumferential APC. And the goal with this is to cause some sort of inflammatory reaction there and help the tissue come together better with some fibrosis after the more definitive closure method that we'll use in a second. So pretty straightforward. We just APC around all the edges where we think the tissue is going to come together. And then we proceeded to the definitive closure method, which in this case was the endoscopic suturing device. So our goal here is basically to use this device to make full thickness sutures. And we chose to do sort of a running suture around the defect and then close it. And especially in this location, our main considerations are just grabbing enough tissue, but also not closing the pylorus, which is not too hard. It's far enough away that we easily have a window here. And as you can see, the steps are that device that's coming out is a tissue helix, which is used to grab the tissue, pull the tissue into the device, and then the device has a suture driver that just drives the suture through the tissue. And it's a series of complicated little firing and little dance kind of outside the patient to make this all happen. But we do here perform a running suture with 4 bites around the defect. And I'll just zoom forward. It's sort of repetitive action here. After we get the 4 bites complete, there is a cinching device. This is it. So you pull tension on the suture, it pulls everything together, and then it deploys a cinch. So what you end up at the end is the needle, which acts as a cinch on one end, and then the suture and a cinch on the other end. This is after the first suture. So the pylorus is clearly still open. That's where the defect was. You can't see the defect anymore. We interrogated a little further here. But as sort of a belt and suspenders technique, we opted to place a second running suture around that. And this is the final result with the complete closure of the defect on the left. And you can see the device is very powerful in terms of, altering the anatomy here. We completely closed over the defect. You can pull a lot of tissue in and really get good closure there. So the patient did really well. Her drain output immediately decreased from about 200 to 500 cc's per day down to 30 to 50 cc's per day. We placed an NJ at the same time of the procedure, to allow for healing of that defect. And I think for a week or so, she was on NJ feeds, and then we trialed her on liquids and then progressively advanced her diet. Her drain output remained low, implying that leak was closed. And then she was discharged, and she's doing well, although we don't have really long-term follow-up yet. And here are some learning points. So I want to highlight this because we've talked about this before. I presented another more delayed fistula closure at a prior conference, and all of these are just really hard to treat. We've tried multiple endoscopic methods for closing leaks and fistulas, such as stenting, clipping, suturing, gluing, basically anything you can think of. And despite that, efficacy still is not that great. So in this study, it was a retrospective study with this device of 56 patients. And these were a little more chronic fistulas, not acute leaks necessarily. These were 9-month-old in average. And they all had immediate technical success, as we did, and they closed the fistula with suturing. But you can see on the right, this curve showing basically failure over time, and only 22% of patients had a persistent success at 12 months. Some of them underwent repeat closure, and on a repeat closure, even a very small percentage of them actually successfully were closed. So it's really just, again, to highlight that it's a very difficult problem to treat, and we still have some more work to do here. Thank you.
Yeah, I remember this case. Unfortunately, with the perforations, and especially when it's post-surgical or they still have a leak, oftentimes the surgeons kind of wait a little bit longer than we would like before they notify us. And a lot of the times when they're more chronic, perfs or leaks, the surrounding tissue is not very viable for us to be able to perform endoscopic closure. You can kind of sort of imagine it as pulling, suture through cheese. It's just going to rip right through. This case, I think, is a little bit different. One, it wasn't there for 9 months like a fistula, like you showed in the that paper, but also we had a large area in the stomach to be able to, go out further and take healthy bites of tissue to allow for good endoscopic closure, because she had one surgery. I think she had a take back as well. And so she's done quite well now, at least in the short term with the endoscopic closure. We'll have to see, hopefully long term this sustains, but I think her particular case, because it was a little bit more of a shorter interval, hopefully she'll have better success than with those chronic fistulas that you showed in terms of the data.
We've seen in our service a number of patients who've had leaks, perforations, things like that, that the upper GI series was negative. And I would say it's like 50% of the time. And just the clinical judgment over how the patient's doing, persistent and infectious symptoms. Or my favorite test is just give the patient some Jello and see what comes out of the drain. And that's what happened with this patient. But she'd been smoldering on for a while, never quite totally recovering after a gram patch, some infectious kind of stuff. And the upper GI was indeed negative, but you have to imagine you have to drink enough contrast that generates enough pressure to go out the hole, which may be opposite gravity, right? Contrast is going to scrape to the bottom of the stomach, and if the hole is at the top of the stomach, it's not going to work. Yeah, the clinical judgment, really trumps everything here. You get a collection that doesn't make sense, get a history that doesn't make sense, then sometimes endoscopy with fluoroscopy can really see everything.
Yeah, Satish, I forgot about the green Jello test. She did have a positive green Jello sign. I should have mentioned that.
Big fan.
Yeah, the surgeons will oftentimes do sort of the methylene blue, drink methylene blue, watch it come out the drain.
Jim Marion does that too sometimes.
Yeah, Jim does the methylene blue test just on the inside during colonoscopy. Any other questions, comments?
Yeah. Why didn't you use the Ovesco clip, the over the scope clip? Because it was close to the pylorus, or was the suturing the method of choice?
Great question, Jerry. So there are a couple of reasons. So the Ovesco clip, for the fellows that haven't seen it, it's an over the scope clip. It kind of looks like a bear claw. We're limited in terms of the size diameter of the clip. The biggest clip is a 14 millimeter clip. And for a couple of reasons here. One, as you alluded to, is that it was very close to the pylorus. And whenever we're working in that area, we worry if we're going to close off the pylorus and, cause further issues. The second in this particular case is that the area sort of immediately surrounding the ulcer was not very healthy and viable tissue, in my opinion, and I was worried that I wasn't going to have good durable closure for the Avesco. And then the third is that it was sort of along the lesser curvature. And for the Avesco, you really want to have a nice en-face view with your scope. You ideally want it to be really straight so you can equally pull up nice amounts of tissue into the cap. When we're along the lesser curvature, the scope has oftentimes a little bit of a bend, a little bit of a U-turn. And so we're not really en face to be able to get an adequate amount of tissue typically within the clip. So for a variety of reasons, we elected in this case to go with endoscopic suturing.
My question is, would you always default to endoscopic suturing because you know how to suture?
No. And as Nick alluded to, so a lot of times we'll do multiple modalities of closure. But for example, like a great use of the Avesco clip is in patients who have persistent leaks of gastrocutaneous fistulas from a prior PEG. And for those cases, oftentimes you can have a good endoscopic en-face view of the fistula tract. We can denude the mucosa a little bit with APC, and then you put an Avesco right on top, and oftentimes that's all you need to do. So you have to kind of approach the closures depending upon the size, the location of the defect itself, and then what's the viability of the surrounding tissue. So with that,
I was just going to ask, this is Randy Steinhagen. I think the results of that study, which show very high short-term closure and not so great long-term, I think you've reinvented what we've learned surgically from the outside, which is basically if you try to suture a chronic hole closed, it usually doesn't work. You have to resect the tissue because the chronic tissue doesn't heal. And I wonder if you need to be more aggressive about your debridement before you put the sutures in, because you're dealing still with too much chronic fibrotic tissue around the edges of the hole.
Yeah, that's a great point. When we get consulted for these chronic fistulas, we are very upfront and honest with the teams that consult us and with the patients, because chronic fistulas endoscopically, despite all of our tools, we're not very effective. This particular case was unique. It was more of a shorter term ulcer. So I think we have to take the data that Nick showed and apply it with a grain of salt with this particular case, but you're exactly right. The chronic fistulas are very, very challenging for us, and we run into the same issues endoscopically that you guys do surgically. So with that, we'll stop.
Don't forget Nick's bonus question.
Yeah. Sorry?
Don't forget Nick's bonus question.
Oh, bonus question. So that quote is from Apollo 13. This device is made by Apollo. But I didn't want to be too upfront about using device names in the title, so that's
okay.